Good afternoon. We're just about to start, and would someone like to respond back to us via the chat box that they are able to hear us okay?
Yep.
Okay, great. Then we will get started. Mr. Hoffman, Dr. Hoffman?
So good afternoon, everyone, and thank you for joining us for this, the first in a series of communications from the Department of Health regarding the traumatic brain injury waiver approval by CMS that was effective on September 1st. As I said, this is the first in a series. There are going to be other webinars, and there will be in-person meetings that will be sponsored by the RRDCs in each of the regions across the state. So participants, providers, and other interested parties will have an opportunity to attend and participate in an in-person meeting on the implementation of the TBI waiver at some point in the near future. We're very pleased that the department was able to obtain CMS approval of this waiver. There are a number of changes associated with the waiver. Some of those changes were imposed on us by the federal government as part of a new approach to 1915C waivers. We're anticipating that other 1915C waivers, both in New York and other states, will look more similar to this approved waiver than other waivers we've seen in the past. With that said, I'm not going to provide a lot more detail except to say please be patient with the process of rolling out this information. There's a lot of information. We're going to try to provide the information in a clear and concise manner so that all constituencies that are interested in the waiver, participants, their family members, providers, their employees, RRDC personnel, and other advocates have an opportunity to consume the information in a way that's understandable and will allow for maximum efficiency and the least disruption in care. So with that, I'm going to turn the floor over to Beth Nazio, who's going to lead this webinar.
So first and foremost, we have you muted for purposes of just keeping the conversation focused on the slides that we'll be presenting. If for some reason it sounds as though you're getting some feedback or from us, just indicate if there is a problem via the chat room. And I would also ask that even though we have you muted, that you additionally mute your own phone so that we're sure that we have no other problems. So one of the things that we're going to be, ready for the next one. So today what we're going to try to do is I will tell you that this is going to be a high-level review of the application. Those of you who are familiar with the document, it is quite detailed, and it's not the sort of thing that you can get through it quickly. So I would encourage you all to please spend time reviewing the application content directly. It is available in 2 locations. One on the MRT 90 website, which is what the site that you use for purposes of accessing all of the waiver transition information. And additionally, it is available with the TBI waiver program on the department website. So please review that information. If after you've reviewed that information and you have additional questions and they're not addressed by with your conversations with the regional resource development centers, we would encourage you to then use the TBI mailbox, which is tbi@health.ny.gov. Those of you who have recently submitted questions to that mailbox, we are attempting to respond to you directly to each individual email. There were a number of emails that came in early on in the application approval process that we are also compiling into one large FAQ, which will be posted on the 2 sites that I mentioned to you earlier, so that hopefully we'll deal with your individual issues as well as the global issues that deal with the program as a whole. So the first issue that we'd like to talk about is the UASMY. right? This is probably one of the biggest changes with the approval of the application. However, it is not a change that we were not aware of. If you recall, those of you who have been providers for quite some time received the notification back in 2000, I believe 13 or 14, which discussed the fact that we were going to implement the UAS-NY. At that point in time, it was an initiative that was focused for all individuals in the Division of Long-Term Care that were getting long-term care services. We were looking to move to implement the UAS back then. And what happened is because of the fact that we submitted our application for renewal in 2013, and there was a delay in getting that approval process, we later withdrew the requirement that anyone needed to have the UAS done pending the approval of the application. Unfortunately, we didn't realize that it was going to take us 4 years to get that application approved. So as such, we've had quite some time where we've not utilized the UAS-NY, and so now for many providers, it's a new process. Any individual that is currently on the waiver that has a PRI done and is currently receiving waiver services, they will not be required to have a new UAS-NY done until 1 year from the date of the previous level of care assessment. So if they have a PRI that is currently on their record in part as part of their waiver eligibility, they will be required to get their UAS-NY completed at the point in time 1 year from that level of care assessment. The 1 year date for renewal of level of care and reassessment of level of care is not new. We'll be switching from the PRI and screen onto the UAS-NY. Additionally, the department has a different set of regulations that pertain to nursing facilities and to institutions. So there are folks who may be moving out of nursing homes into the community that do not have a UAS completed. The nursing homes are still continuing to use the PRI and screen. So as such, any individual that's transitioning from the nursing home into the community and coming onto the waiver will be required, and they have a PRI and screen completed, they will be required to get the UAS-NY completed within 90 days of their waiver eligibility. The UAS must be completed by the trained assessors, which is a registered professional nurse. They access the system via the Health Commerce system using their UAS accounts. For those providers that are currently approved as waiver service providers and are accessing the system, you will see that we've expanded your roles so that now you have full access to going into the UAS. You're able to review the information, and should you have a nurse that's a trained assessor, you in fact can go in and complete your assessments. So we have, if you've noticed that there's a change of role, that was a deliberate activity on our part to expand your role so that you had more access to the information and ability to participate in the assessment process. I also want to just remind you that, again, level of care determinations are to be monitored by the service coordinator so that they don't expire, so that they should be tracking when the initial assessment was done and when the reassessment will be due. They should be maintaining that information in their service coordination files because it is subject to audit at a later date. Now, as you're aware, there was a lot of feedback and discussion regarding the implementation of the UAS as it's related to identifying cognitive deficits for individuals with traumatic brain injury. We've done quite an extensive review on the tool. We've participated in a national work group which continues to look at this issue. And as a result, we've decided, and it is included in the application, to offer an alternate route for those individuals who, for some reason, have failed the level of care requirement and we feel should have the opportunity to participate in an additional review. This is now going to be a three-step process. So an individual will have an initial UAS completed. That UAS hopefully is completed by either a child or a nurse that is involved with the individual. It is established, the level of care score is established. If that level of care score does not meet a score of 5 or more, then we encourage the participant or applicant to seek a second assessment. Ideally speaking, that second assessment would be completed by the regional nurse evaluator, hopefully knowing that that person has some history on the individual, being involved in their intake process and knowing some of their history, or in previous review of service plans. So the nurse evaluator would then go out and do the second assessment. At the point in time that the second assessment is completed, should the person not be nursing home level of care, continue to have the same score below a 5, the individual will be advised of the alternate route system. Now, what that means is once there are now 2 completed UASs, both of which have indicated that the individual does not meet nursing home level of care, we will inform the individual that they have not met level of care. They will be provided a notice of decision and then encouraged to come in for either a case conference and or to also seek a fair hearing. The third step of the process, which is what we consider referring to as the alternate route process, we hope to work parallel to the fair hearing process and case conference process. So while the fair hearing is going on and while the region is conducting a case conference, we're also encouraging those individuals to reach out and to get a clinical assessment done, which would give us an additional resource to review in terms of establishing nursing home level of care for that particular individual. Now, as Dr. Hoffman mentioned earlier in the conversation, the approval of the application turned out to be a little bit of a surprise for us. So in many cases, we are playing catch-up in terms of trying to implement the necessary policies and procedures to get the changes in the application in place and working for everyone. So at this point in time, we do not have the specific protocols in place for the third assessment process, for the clinical assessment process. We hope to have that information available shortly. It will be an independent review. We will be garnering information from prior assessments, looking at additional case history on the information in the individual's case. We will also be looking at recommendations and information provided by the RDC, and that will be in addition to a formal clinical assessment done by a professional with experience in traumatic brain injury, cognitive deficit, and then that will compile one complete report, which will be sent up here to the Department of Health, and a consultant will, or a team of consultants will review that information and make a final determination regarding level of care. Now, while that process is in place, the individual is also entitled to their due process, and we encourage them to continue through the fair hearing. Should the fair hearing process not support that the individual is level of care, the individual will still be offered the opportunity to continue the alternate route process. And should, in fact, the administrative law judge determine that the person is, in fact, nursing home level of care, then we will live within the decision. And then what will happen is any individual that is determined eligible via the fair hearing process will be, just like everyone else, subject to an annual review. And so 1 year after that fair hearing date, that we will then seek a new level of care assessment. Now, there's been some discussion about what happens should the fair hearing decision not be positive for the individual and the impact that it has on the provider and the providers that have provided services during the aid continuing process. I can tell you that one of the things that you will see on our to-do list later on in the presentation is that we will be doing a presentation or a training for the administrative law judges so they too are familiar with the changes in the application content. Additionally, just as the current practice is, any individual who is determined not eligible in the current process by way of a fair hearing is issued a notice of denial at the point in time that the fair hearing decision is rendered. And when that decision is rendered, it's a notice of decision that generally has a 10-day effective date in order to give us enough time to inform that person of the decision and to help maintain and successfully transition them to alternate services once the waiver is no longer available to them. That process has not changed, and that process will remain in effect. All right. The next slide, we talk about the definition of traumatic brain injury and the other eligibility criteria for the waiver. Now, I know we've been very focused on the whole process of the UASNY. However, that is only one component of the eligibility process. There are other criteria that we're looking at as we continue to assess someone once they come into services or apply for services. So what you see is in the application, in the prior application, the eligibility language was not necessarily consistent with the enabling legislation that established the waiver program. So what we've done is basically a cut and paste of the enabling legislation into the application, which really further describes such things as the acquired brain injury. It focuses on issues such as degenerative conditions and what happens with individuals with other conditions that may appear as a brain injury but are not medically supported as a brain injury. So all of this eligibility criteria is not new to us. It is the criteria that, frankly, legislatively we've been mandated to consider, and we're just now putting it in the application. Then I encourage you to go into the application and to also look at the various reasons that we've now included for reasons for discontinuation of waiver services, because that has also been expanded. The criteria that the individual has to be between the ages of 18 and 64 upon application remain the same. A new language that is now in there is the age of onset of the TBI. So individuals who acquire a traumatic brain injury or have a diagnosis of brain injury before the age of 22, in many cases historically have qualified for OPWDD services and/or the TBI waiver. What this has resulted in the past is sort of a competition of effort in terms of not really being clear as to whether that individual could be better served through the OPWDD system or the TBI waiver program. So we've added language that the Regional Resource Development Center, in the process of going through and working on the intake process and reviewing the eligibility information, can also decide whether in fact the person is more appropriately served in the OPWDD system. And we encourage the Regional Resource Development Specialist to have that conversation with the applicant and the family, mainly so that we're sure that the person is ultimately going to get the services they need from the best program, and also not to send an individual through a lengthy TBI application process that could ultimately result in the fact that they're not eligible for waiver, the TBI waiver, and are in fact eligible for the OPWDD system. So that is new language. The fact that the individual must have Medicaid coverage that is consistent with community-based care is not new. And there's been quite a discussion in the past about whether that person needs to be Medicaid eligible at the time of application or whether the service coordinator is to help them to secure Medicaid eligibility. And it is our position that the individual should be Medicaid eligible at the time of applying for services. And again, that's done for a number of reasons, but mostly so that it's sort of a protection for the provider to ensure that the individual is ultimately going to be eligible for waiver services. And also just in terms of timeliness, because we have no control over the Medicaid eligibility process, so it will expedite enrollment into the waiver if in fact that individual is Medicaid eligible at the time they apply. The individual must be assessed to need nursing home level of care. Okay. And then the individual needs to have a residence identified in the community because we need to know where waiver services are going to be provided, so we can't really develop a service plan without knowing where those services are going to be provided for the individual. Part of the provision of our services is ensuring that that person can be safely served in the community and has a safe residence in which they're going to be residing. Since the application was submitted, there were new federal regulations, the HCBS regulations, which put a tremendous emphasis on community settings. And as such, we've in this application process, made it very clear as part of our compliance plan to CMS on HCBS regulations that no waiver service will be provided in a congregate care setting. And as such, we're determining a residence, regardless of whether it's in an institutional setting or in the community, of 4 or more unrelated individuals as not being an appropriate setting for waiver service provision, and therefore that individual would not be considered eligible for waiver services, that we feel that a home of 3 or more unrelated individuals still is maintaining a good community life and is appropriate. Again, the services and the supports offered through the waiver must be sufficient to maintain the individual safely in the community. And additionally, the participant must actively participate in their service delivery. We've had numerous times in which someone might come onto the waiver and then in fact determine that they don't really want to participate in that service provision. They don't want to participate in the development of their service plan. Person-centered planning and the provision of services requires the full support and involvement of the individual. And if that individual is not going to participate in those services, then that would also have to be considered.
So Beth, let me just interrupt for a second. We're getting a lot of questions online that are not really directed to what Beth is talking about now. So this goes back to what I referenced earlier. Please be patient with the process here. We have a number of slides of information we're going to be sharing today. This is not the end of the rollout of the TBI waiver, it's the beginning. So there will be an opportunity for all of these questions to be addressed. We are not going to stop the presentation this afternoon to answer individual questions. I just don't want folks on the line to get frustrated that your questions aren't being answered. We will get to them. It may not be today.
So every 1915C waiver application requires limits, right? And those limits are such things as the enrollment numbers, what services we are going to provide, what the cost of those services are, and then you'll see with this application, for the first time ever, CMS required that we actually impose some specific service limits that we traditionally did not consider. So first and foremost, we do have a limit as to the number of individuals that we say that we can serve on an annual basis in the application. So we are now, since we were approved effective September 1, 2017, in year 1 of our application. And what we've indicated to CMS is that our enrollment for year 1 of our application will not exceed 3,615 individuals. And then what we did was we trended out our enrollment over a period of time. We actually did about 8 years period of time. And then based on that, projected out what our enrollment numbers should look like over the 5-year period of the application. So these are the numbers that you will see, which would be the maximum capacity of new individuals or the current enrollment that we can provide services to on a statewide basis. Now, our current enrollment numbers actually our enrollment numbers seem to be going down, which is sort of interesting. But right now we are several hundred participants away from the 3,615 for year one, nor do we anticipate that by the first year of the application period that we will be close to the enrollment projection. So we're good in terms of our participant projections. All right, so now we have a lot of discussion regarding the service plan development. All right. For all intents and purposes, there really isn't a lot of change in terms of how we're handling service plan development. The biggest change that impacts the individual is that just as NHTD did with their last application approval, we moved to a one-year annual service plan. So what that means is that individuals will have a full RSP completed on an annual basis. All right. The process for doing the initial service plan remains the same. Now, obviously, as we get more involved in the implementation of this application, we are going to be making significant changes to the program manual as well as many of the forms. Many of the providers and participants have complained about the lengthy process of our service plans. We've had several times that we've requested comments on how to improve the service plan. So we anticipate that in conjunction with the implementation and development of the new program manual, we will also be revising our service plan forms. So the service plan will be developed on an annual basis. The RDC will review it. It will be submitted 60 days prior to the expiration date of the plan. The RDC will approve it. They will provide their comments using the review form, which is given back to the service coordinators, and basically that the process remains intact. There may be additional assessments that will be included with the service plan review process, mainly because of the fact that for some of the individual services, we've changed the types of assessments and how some of the assessment processes are done for some of the services. So there might be changes in what assessments we're looking at in conjunction with the service plan development, but the process basically remains the same. Okay, individual service reports. As part of the service plan review, will be required by every provider when we do the annual review. Additionally, those individual service reports will be completed at the 6-month review. The difference being that it will be up to the Regional Resource Development Center to establish if, in fact, they want the providers to give the region the ISRs at the 6-month review. However, it is mandatory on the annual reviews. Right? Team meetings are to be conducted every 6 months. We've received several questions regarding how is a team meeting conducted. There is no difference in terms of how a team meeting is conducted. It's the same 6-month review team meeting that we're currently doing. The service coordinator remains responsible for ensuring that all waiver participants receive a copy of the approved service plan. Additionally, I know there's been some circumstances in which we've not required a service coordinator to provide an ISR. Going forward, service coordinators will be required to provide an ISR regardless of what services the individual is receiving. So all service coordinators, even for those individuals that might have service coordination and other services, will be required to complete an ISR. Right. The RSP is rewritten and approved by the RDC annually. It's reviewed every 6 months at a team meeting, or when there's a significant change in the person's condition, living arrangement, or should the person actually request that they have an additional review of their services. The RSP, as I mentioned, is due to the RDC 60 days prior to the last day of the current service plan, and the RSP must include the ISRs. The RDC reviews the team meeting summaries, advises the service coordinator if additional information is necessary, may seek corrections onto the service plan, and the plan is approved for the 1-year period that is from the date that the plan started. So this seems to have brought about a lot of discussion among our providers and participants. The current plan and system is for any individual that currently has a service plan, an approved service plan in place, that individual will not have an RFP submitted on their behalf until the 60 days prior to when that current service plan expires. So it's 1 year from the date of the current service plan, and then the 60 days prior to the 1 year. So you're submitting everything with the 60-day advance notice to the RDC, but it's now moved to an annual date. There is no reason at this point in time for anyone who currently has an approved service plan to submit a revised service plan and/or an addendum unless that individual has a significant change in their life, changes their living arrangement, or seeks to have an addendum completed on their service plan. If it is an approved RSP at this point in time and the person wishes to have their service plan reviewed, that review will be completed as an addendum, not as a new RSP. Additionally, any individual that currently has services in place in their current service plan that is somehow impacted by the new service limits, those service limits will not change until that individual has a new service plan 1 year from the date of the current plan. So I do not anticipate that any individual that is currently getting a waiver service that has an approved service plan would be subject to a reduction in service unless their conditions or needs warrant that reduction. There is nothing in the application in terms of the limits that would impact anybody at this current time in terms of the new service limits. The clock starts ticking at the point in time that that individual has a new plan in place. And there's a reason for that. At this point in time, we have to afford our participants sufficient notice. They have to be afforded a team meeting in which they know what the new limits are, and they have to be afforded due process should they not agree with the terms of the new service plan. So there is no reason for those plans to change. Now, I know that providers are concerned that there's a significant, they think there's a culpability as a provider in terms of documentation to support that they're approved to continue to provide those services. The RDCs are currently preparing addendums which will go out for every individual that has a service plan in place that will indicate what the new plan dates are. Those addendums will be provided to the participant and to the service coordinator, and the service coordinator is responsible to distribute copies of those addendums to those providers that are indicated in the participant service plan as providing services to that individual. Fair hearing. All right, as I mentioned, there are, we are going to run into issues associated with the UAS and the request for fair hearing. There has been concern presented that should an individual who's requested a fair hearing has aid continuing, and in fact, a later decision is warranted, that the person is determined not eligible and supports the decision of not nursing home level of care, providers have indicated that they are concerned that they somehow are not going to be reimbursed for the services that they provided during the aid continuing process. I've now been working with the waivers for over 8 years. Never have I known of a case in which an individual who was later determined not eligible for waiver services that had aid to continue, were they subject to having to pay for their services. And what we have made it a practice of in the course of the last several years is that we have advised providers that if they need a copy of the fair hearing decision, we will provide them with a copy of the fair hearing decision. and if necessary, a letter that indicates that the person had aid to continue, was receiving services during this period of time, and that the fair hearing decision was rendered that the person was no longer eligible for services. Again, another NOD is issued at the time that the fair hearing decision is issued, and it has it is not a retroactive notice date. It is a prospective notice date, and can actually, in some circumstances, we've extended it to a period of time to ensure that individuals are successfully transitioned to other services. The point of the fair hearing process is, again, to not cause harm to the individual. So we will do our best to ensure that all provisions are in place to protect the individual, that they get services up to the date that the ALJ determines that for some reason the individual is no longer eligible for those services. So as I mentioned earlier, I encourage you all to please look at Appendix F of the application, which goes through and very specifically lists some of the reasons for denial or discontinuation of services. I would also remind you all that housing, the TBI housing program, is not a Medicaid waiver service and is not subject to fair hearing. There is a case conference system that is established within the TBI housing program manual that serves as our due process for issues related to the housing program. You will see that in the course of the next couple of weeks, we have to catch up our NOD forms in conjunction with the rest of our changes. So you will see that what will most likely happen is that the RDCs will be checking off other, and will be using the new language that is contained within the new approved application for reasons for discontinuation or changes of services. Serious reportable incidents. You're going to see when you review the application in Appendix G that we've made some changes to the definitions of serious reportable incidents. We've also made some changes in terms of what are recordable incidents. Again, this is another opportunity where we are going to have to go back and revise our forms. What we will be looking to do, since we're looking to consolidate many of the practices between the NHTD and TBI waiver programs, we'll be looking to consolidate some of the forms as well. I think that serious reportable incidents is certainly one of them, where what will happen is it will be the same form used by both waiver programs, and there'll be a checkoff where you delineate whether it's a TBI participant or an NHTD participant. We also need to set up a system where those forms give us a clearer identification of what the issue is. Sometimes you can read those initial incidents and not really be sure what happened. So we're looking to clear up what exactly happened, some basic information about the individual. So for example, what their age is, where the incident actually happened. So we'll be looking to get some more identifying information with the initial incident report. And then what we're going to try to do is to make it sort of a continuous reporting process. So as we do a 30-day report, you'll be referring back to the original document, and so it'll just be a continuation so that when the entire investigation process is complete, you'll have basically a sequence of events that occurs via the form. So there's going to be some significant changes to how we do serious reportable incidents. We're going to be looking for significant input from the provider community, since this is a very burdensome process, and we want to be able to make sure that we're getting accurate information, timely information, and additionally, we want to make sure that incidents are properly investigated and closed out when necessary. To have a serious reportable incident go on for months on end without any closure is just no longer acceptable. So we have to find ways to streamline the system so that we can get to the root cause of the incident and what the outcome of the incident and how the situation was remedied. So in terms of serious reportable incidents, the categories of abuse, neglect, violation of a person's civil rights, missing persons, death of a waiver participant due to circumstances unrelated to natural cause or illness will be reported as SRIs, as well as unplanned hospitalizations, any possible criminal action, and medication error and refusal. So those are what are going to be the standardized serious reportable incidents. How we fit some certain incidents into those categories, I think we need to discuss further. But those are how we've basically streamlined the SRI process. In terms of our definitions for these incidents, we turn to the definitions that OPWDD uses in their regs so that we're consistent, mainly because we did not really have any source documents to refer back to in terms of regulation to actually support the definition of the incidents, so that's why we turn to the OPWDD definition. Then we have our reportable incidents. All right. An injury that is accidental in nature should be reported to the RDC, and then the RDC will determine if, in fact, it is an SRI. If it's, if it's an incident that an injury that doesn't result in an emergency room visit, doesn't result in an emergency hospitalization, it may end up just continuing as a reportable incident and not go through the SRI process. Death of an individual due to natural causes. Obviously, we have folks that many of which may be in hospice or are in long-term care situations where we know that their death may be imminent. To include them in as a serious reportable incident when we're directly involved in their care and comfort in the community really does not really seem to make much sense to put it in as an SRI. And then the recordable incidents will be maintained by the waiver provider and reported to the RDC on an annual basis. Again, these are all processes that we're going to further define as we develop the program manual, and we will be looking for input from providers going forward in terms of how to best modify the system and make it more user-friendly. Now, in terms of service definitions, that is all laid out in Appendix C of the waiver application. You will see that there is some changes in the terminology of the service definition because we primarily sought to go back to the CMS technical guidelines and to use the CMS service definitions established in the technical guidelines. The new CMS has revised its application format, and as such, we had to assign a taxonomy to each one of the waiver services, which means that we have to directly connect that definition of that waiver service to a service that appears in the CMS technical guidelines. So as such, when we worked on the service definitions, we looked to make those service definitions more compatible with CMS so that therefore going forward, we would not necessarily be as subject to any audit process or questions because we're consistent with what the CMS technical guidelines require. So in terms of the service definitions, although there's some change in the language, I can't say that there's a significant change in the actual service definition. However, we did make changes in terms of the qualifications of the staff providing those services. So let's talk about that a little bit. Let's remember when this application was submitted. It was developed and submitted in 2013. At that point in time, we had already begun communications and conversations about moving the waivers to managed care. We were very concerned about how waiver service providers would transition into the managed care environment. So as such, what we did when we looked at the service definitions and the qualifications for those services, we looked to those individuals and qualifications that would most likely be providing those comparable services in a managed care environment. So therefore, you're going to see that the emphasis is on licensure, the emphasis is on certification, and those requirements in addition to experience and history in traumatic brain injury. So as a result, you're going to see that there is a significant a change in the level of certification and licensure that we're expecting of our providers. Any staff person who is currently grandfathered in as a service provider will remain grandfathered in as long as they remain employed with the provider that is approved to provide those services currently. If a staff person leaves an agency and goes to a new agency, they must meet the new qualifications because it's considered a new employment opportunity. And what we don't want to have happening is we don't want the new hiring agency to be culpable in that at a later date upon audit, they could be found to not be in compliance with the qualifications. So the best way to protect the provider is to ensure that any new hires that they're bringing on meet the new qualifications. Additionally, we did away with what I refer to commonly as the Chinese menu of qualifications. Under the old program manual, there was, if you met the qualifications in A, you could be a supervisor, or you could be a service provider, but if you were B, you had to be supervised. We now stick with a straight, you meet the qualifications or you don't meet the qualifications. So there's one set of qualifications, and it's not broken down by an A category or a B category. This often leads to a lot of problems. That A and B often leads to a lot of problems upon audit. What ends up happening is that literally the Attorney General's office and OMIG have had to seek out guidance in terms of whether someone is qualified before they can actually determine if, in fact, a provider should be cited for the staff qualifications. Providers have to be aware of the fact that they need to, we only require the qualifications of one staff person for each service at the time that they apply to become a provider. The providers are responsible for ensuring that on an ongoing basis, the staff they continue to hire once they are approved meet the qualifications established in the waiver application. We've given some thought to having providers update that information, at least with one staff person per service on an annual basis, so that we can in fact say that we confirm that that a provider continues to hire qualified individuals. We've not quite worked out how that process would work, but that is certainly a consideration at this point in time. All right, so in terms of services, respite services, the biggest change in respite services is it's not offered in a congregate care setting. It remains having to be provided on a 24-hour block of time. The primary location for the service is in the participant's home or a non-congregate care setting. And then, again, it is reimbursed in a 24-hour block of time, and respite cannot be provided at the same time as another service is being provided. So an individual can't be in a respite service, receiving respite services and getting HCSS at the same time. Now, this service, quite frankly, in terms of utilization, I think if we have less than 10 individuals a year who are actually using respite, that's about it, because most of our folks who need respite are already getting HCSS and they're using their HCSS hours to provide that respite. So we don't anticipate a lot of issues associated with any changes on the definition of respite. All right, service coordination, right? Service coordination has not really changed in terms of its definition. We still have initial service coordination and we still have monthly service coordination. We have always maintained that individuals on the TBI waiver program receive monthly face-to-face contact, right? That has not changed. The biggest change in service coordination has been that we've increased the caseload to 25, from 1 to 17 to 1 to 25. Now, I know a number of the providers were hoping that we were going to reduce the caseload size, right? The main reason for increasing the caseload size is knowing that we're moving to conflict of interest criteria as it's related to service coordination. We're very concerned about capacity issues and our ability to provide service coordination to all of our waiver participants and applicants. So our goal in increasing the capacity of the caseloads was in the hope that we were going to continue to meet the needs and the demands of providing service coordination in a conflict-free environment. So that is primarily the reason for the change in the caseload change. Additionally, service coordinators still continue to have to meet with the participant quarterly in their home. We are going to be conducting another separate webinar on the conflict of interest criteria. We continue to work with the Centers of Medicare and Medicaid on the conflict of interest criteria. Every provider that is seeking to provide service coordination services will have to submit a compliance plan, which will go to the regions and then to the department in terms of how they are going to institute the firewalls to ensure that there is no conflict if they're going to continue to provide service coordination and other services until our transition to full compliance in January of 2019. So more to come on how those compliance plans will be set up. We're hoping to come up with a standardized template that will make it user-friendly for the service coordination providers to give us the information that we need to ensure compliance. Additionally, the Department of Health will be participating in a monthly call with CMS, because between now and the transition of January of 2019, we have to continue to demonstrate to CMS that we are seeking to maintain our compliance with the criteria, and we also have to tell them what steps we're taking to get into full compliance. So it will be part of an ongoing communication with CMS, and there are some very measurable tasks and activities that we have to demonstrate to CMS that we've completed, which move us along the lines of getting in compliance with the criteria. Now, in terms of service coordination, we do have some additional criteria in terms of service coordination supervisors, all right? That is primarily that if there are 2 or more service coordinators employed by a service coordination provider, there must be a service coordination supervisor. The supervisor must meet with each of the waiver participants served by the staff they supervise at least annually. And the main justification for that criteria is that I'm not quite sure how you sign off on a plan of services for an individual without knowing who that person is, without having a visual picture of what needs they present, and how they are able to communicate their needs to the service coordinator in order to participate in that plan development. So it's not a decision that was made lightly, but it was a decision that was based on logic in terms of trying to connect the service provider to the user of the service and ensuring that they are able to actually identify who is on their caseload and why they're getting the services that they have in their service plan. Service coordination supervisors must meet with their staff monthly, and I frankly know that most of our service coordination supervisors are meeting way more than monthly with their staff, so I did not think that that was a tremendous requirement. And as they are currently doing, service coordination supervisors must review and sign all service plans. Now, a service coordination supervisor may also maintain a caseload, okay? But again, that is a matter of the service coordination provider to determine what's physically and realistically doable in terms of the workload. Obviously, if you have a service, we don't say that there's a limit in terms of how many people a service coordination supervisor can supervise. The minimum is 2, but there is no maximum. So obviously, if you're a service coordination supervisor and you're supervising 20 service coordinators, the fact that you're going to be able to maintain a caseload of 25 is, I think, probably you would be very close to death by the time you did a month or 2 of that. So again, it has to be what's realistic and practical for the employment of the person. Assistive technology. Now, assistive technology is one of those services where we actually increased the limit. Right. So where traditionally it was $15,000 per 12-month period of time, an individual may now use $35,000 per 24-month period. Again, that 24-month period does not begin until you approve a new request for that person. So if a person got assistive technology 2 months ago, that limit does not go in place until they request a new assistive technology request, present a new assistive technology request. So the limit starts at the point in time the next request is made. The other thing I caution all providers about is that we are eliminating the flat administrative fee that was in place for the provision of assistive technology. So before everyone goes and gets all upset that they're no longer going to be providers because there's no incentive to them to provide those services, what we are requesting is that included in the definition, all right, we provided language that says that the costs associated with the assistive technology, the evaluation of the assistive technology for the needs as it's related to the needs of the participant, the implementation and the oversight of the technology, and the training assistance for the participants or others involved with the care of the person are all costs that the assistive technology provider can include in the cost of the assistive technology project or device. As we develop the program manual and more protocols, we will get more specific as to the guidelines associated with that. But for now, do not think that it's just that the administrative fee was eliminated. It has to do with CMS criteria, that we don't get reimbursed for administrative costs. So therefore, technically a provider cannot get reimbursed for an administrative fee because it's beyond the allowance within CMS guidelines. However, they can get reimbursed for services that they provide on behalf of the individual associated with the service. Community transitional services. This is another service that we increased the limit on and will now apply to any individual that is coming onto the waiver from a nursing home after September 1st, 2017. And that amount goes from $3,000 to $8,000. And we had quite an animated conversation with CMS regarding this request. I had to explain to them that these are individuals that are basically, in many cases, moving into an empty apartment. It's not like they're individuals that are moving into an established group home or into an established assisted living arrangement. And as such, the cost of living and the cost necessary to purchase these items has gone up significantly. It continues to contain all of the same provisions that we've had before. We would also suggest to you that if, in fact, it's going to include security, that your providers are aware at the point in time that the individual vacates the apartment, the security must be returned to the CTS provider, and the CTS provider is responsible for doing a debit claim in the eMedNey because they've received the funds back. Right. Environmental and vehicle modifications. Unlike NHTV, this gets a little messy because we have E-mods included with vehicle mods. However, we have not traditionally had a significant number of requests for vehicle modifications. Right. The other issue that I want to point out when we're talking about services such as ATS and CTS and vehicle and E-mods, these are all services that at some point in time are also going to be afforded through CFCO. Right. What we have done is in the waivers, we've taken the limits for these services above and beyond the CFCO amounts. So individuals will be who are on the waiver will have the opportunity to exceed the service limits that are offered through CFCO. The reason why we're doing that is because in the waiver, we've identified it as an extended state plan service. So it's a service that CMS has agreed that we're providing above and beyond what the state plan offers. Now, in the process of doing that, any individual that's on the waiver that's seeking these services will continue to get them through the waiver, not through CFCO, okay, until such time that we fully transition to managed care and we're using CFCO services regularly. So EMODs, again, no administrative fee on EMODs and vehicle modifications, but again, language has been included. The performance of necessary assessments, project management to ensure the modification has been completed during the required specifications. For example, if a provider is investing significant time and energy in terms of going out to secure bids, managing the project, those would all be considerations that would be included in the cost of the project provision. We've always run into problems where we've had folks that we cannot necessarily get a contractor in place because they don't want to take on a project without receiving any upfront funds, and they are looking to get some payment along the way. So we've allowed provisions within the application that will allow the contractor to receive 3 payments, and again, each one's going to be set up as a separate cost form and approved by the RDC, but they will be able to receive their payment in 3 different time sequences as long as the RDC has approved it. There's confirmation that the project is moving along according to schedule, that the project is in fact meeting the standards of the project, but we will allow providers to bill for the service in 3 increments. Again, the amount is now $45,000 per 36-month period of time, so it gives people the opportunity for more of an upfront project, a larger project at the start. And additionally, a clock starts ticking at the time that the next project starts, right? Not before then. There's some additional, you'll see in the qualifications, there are some additional titles that are included in the qualifications. We now include such things as an aging in place specialist, as someone that could do an assessment. There's a home modification, I believe a home modification specialist. So there's some changes in the language in terms of the qualifications as to who is able to do the assessments and who is able to provide the services. Transportation. For TBI, social transportation has not changed, okay? It is still going to be part of the service plan. It will still require that the individual have a separate request, which is submitted to our Medicaid Transportation contract manager. But I do caution you all, right? And this has come up significantly with a number of providers, right? This service is not to be abused, all right? This is Medicaid transportation with the caveat that there are additional trips that can be provided to an individual if, in fact, there is sufficient justification and related goals in the individual's service plan to support the request for the transportation, all right? It is not, 5 trips a week for social activities. It is an indication that the individual first has a social integration need. That need should be included and supported in the service plan. It should describe what type of activities that the person is participating at the end of that trip, and provide a justification as to why that participation in that activity is necessary to enhance the individual's life and is directly related to their rehabilitative services and needs associated with their traumatic brain injury. I've been cautioned by the Medicaid Transportation Unit to not use it as a way to go around the Medicaid transportation requirements. So if, for example, if Medicaid has denied a request for state plan Medicaid transportation, don't think that then it can be included in social transportation and that they're going to approve it, okay? That's a very devious way to try to get around the Medicaid transportation requirements, right? And is subject to significant scrutiny and audit that none of us really want to partake in. So the trips can't be excessive. They must be directly related to the goals of the service plan. You must utilize the transportation grid. The grid is subject to review by and approval by the RDC as well as MAS and Logisticare. The Medicaid transportation rules apply, and they cannot be used to avoid Medicaid transportation requirements. I encourage you all to go to the Medicaid Transportation Provider Manual on the eMedNY site, which has the provider manuals, and you will see the very detailed requirements that Medicaid transportation must live under. And we too are subject to those same requirements. So, home and community support services. Right. CIC? Okay. Community integration counseling. All right. There's been great controversy about the service limits associated with this service. All right. At this point in time, I would like to remind everyone that no individual currently receiving waiver services has been denied their CIC services. There are currently no limits that have been imposed on participants. Right? The new limits go in place at the point in time that the individual has a new annual service plan developed and approved. Right? Additionally, I'd like to remind everybody of the language that's in the application. Right? The service is designed for individuals experiencing significant problems in managing the emotional difficulties inherent to adjusting to a significant disability and living in the community. The efficacy of a treatment must be reviewed if successful intervention and significant process has not occurred within 2 years. At that time, alternative methods require consideration, or continued services must be documented as a medical necessity. Prior to termination of services, a transition plan will be implemented, and services may be extended in extraordinary cases with sufficient medical justification and upon review and approval of the RRDC. So if an individual is going to significantly regress, and there's medical justification to support that regression, the service may continue beyond the 2-year period. Right. Again, 220 hours annually, 4 hours weekly. Right. And those were again service limits that CMS felt were they were looking at such criteria as, first off, CMS was very emphatic with the review of this application that if there was an available state plan service that was comparable, that's what the participants should be accessing. They should be accessing state plan services first. So we ran into significant difficulty having to explain to CMS why counseling provided in the waiver environment is different from counseling provided, say, in the mental health environment or, in other counseling settings. So that was the challenge that we were confronted with. Then when they looked at the limits, the service limits, and the 4 hours weekly became mostly CMS questioning, legitimately speaking, how many hours a week can someone with a TBI tolerate sitting in a counseling session? Mm-hmm. And that was a hard argument for us to make, right? Since most families and folks that I know, other than Woody Allen, okay, usually go for counseling once a week, and it's a 50-minute hour, right? So when we took counseling up to 4 hours, CMS actually felt as though we were providing what was well above the norm in terms of a normal counseling session. Right? So despite what some may think, there was some actual logic in terms of some of the limits that were set. Now, I am not going to be one to say that I agreed with them all. In many cases, we fought vehemently to have higher limits, or in some cases, no limits. The biggest one being HCSS. All right. So in that scenario, we were not in a position where we could vehemently argue with their logic. Right. Again, the assessment time. The reason why the assessment time has been restricted for some of the services is frankly, it's a complaint that comes from the waiver participants. We have a number of waiver participants that say to us that they've been waiting months for their actual service provision because they can't get the service provider in to do the assessment, and it takes forever to get the assessment done, and they actually never get around to actually getting services. So as a result, that's when the idea of imposing limits as to how much time can be spent on assessment, because you're sort of stuck in limbo, all right? So if I have to wait 20 hours while you decide whether I should really need the service and what sort of activities you're going to work with me on, or what my goals are going to be, that's an indefinite period for that participant that's receiving those services. So we look to try to contain the assessment process to expedite actually getting the services offered to the individual and having them receiving services. Now are we on HCBS? Okay. Okay. Home and community support services. As my mother would say on this one, no good deed goes unpunished. All right. So I've created quite the scenario on what to do with HCSS. I know that our TBI providers have been quite concerned about the fact that for many years, nursing supervision visits were offered to individuals or provided to individuals, and there was no reimbursement within the waiver to provide that service or that reimbursement. Unlike the NHTD program, there's a specific rate code, and there is nursing supervision provided within the NHTD waiver. I knew that with the timelines that we were confronted with, that we would never be able to get a rate code in place to add that service to the TBI waiver. So as such, I put provisions within the language of the service definition to allow an HCSS provider to be reimbursed for time that that person, that RN, is in the home with the individual. So we've had quite a dispute about how that information and those hours get documented. If an individual gets less than 24/7 HCSS services, right, in addition to whatever total number of hours that person gets, okay, you will include an additional 12 hours in the total annual hours of that service level for that individual. Right? What you must do is, in the service plan, is indicate that the nurse will be providing additional services for the individual in the home, and indicate that those services will be up to 12 hours annually, and it must be included in the content of the service plan. It does not get reflected on the grid as a separate service. It is reflected in the total number of annual hours of HCSS services. The HCSS staff is not to be present at the time that the nurse is in the home working with the individual. And the reason why is that will be considered a duplication of services. You can't pay for two staff to provide the same service. So the HCSS staff is not present at the time of the nursing visit. They may be there, but the provider can't bill for both individuals. If an individual is getting 24/7, again, the nursing hours are included in the total number of annual hours of service. You're going to note in the service plan that the nurse is providing those services. And additionally, whether for any HCSS service recipient, you're going to include in the ISR what the nurse did throughout that period of time, and there should also be sufficient nursing notes available so that upon audit, we know what exactly the nurse was doing while they were in the home. The board later? No. Again, those additional hours will be reflected with the next service plan, all right? For now, any individual that's getting HCSS, it would be included in the current service plan and the total number of hours of service. As always, on-the-job training is considered an administrative cost and is not billable. Services cannot exceed the approved total annual number of hours included in the service plan. HCSS staff are expected to attend team meetings. The attendance in the team meetings is included in the total number of annual hours. And for a service as critical as HCSS, we would suggest that there really should be a very sufficient justification for why that HCSS staff is not present at a team meeting. All right, ILSP is another service that now has a cap included in it. Again, for many of the same reasons that we used in terms of the CIC justification. How many hours of training a day can an individual tolerate, which is how we got the 4 hours per day. Keeping in mind that most folks that have ILSP are also getting other services. So then the question becomes, how much can one individual absorb in the course of a day, and how many services can you have in a 24-hour period of time? So the big change on the ILSP is that we're asking providers to use the UAS as its tool for developing the detailed plan and the training plan. And the main reason why is that although there's commentary that the UAS might not pick up the cognitive deficits of an individual, one thing we all know for sure, you complete a UAS and you really know what people's ADLs and IADLs are by the time you finish the assessment. So to then put in an additional assessment process after a participant has gone through the UAS just seems to be a little redundant and also quite trying, quite frankly. So we've eliminated the ILSP assessment time. We're advising providers to use the information garnered from the UAS. If at this point in time there is not an available UAS in the system, we are advising providers to use what other available information is contained in the person's service plan, case history, medical history, and use that information to develop the training plan for purposes of moving forward with the service. At the point in time that the UAS is completed, the ILSP might choose to go back and amend their training plan. However, it's not necessary, but it would be required at the point in time that the annual plan is up for review. With ILSP, the participant must be present when the service is provided. The participant should also be present at the time that the training is provided to any other staff or support offered to that individual. There isn't any of us that like the idea that somebody's talking about us when we're out of the room. So anything that we say to staff in terms of how best to work with an individual should be said with that individual in the room and present, and with the opportunity to provide their own feedback. ILSP cannot be provided in a structured day setting. Right? That would clearly be a duplication of services. Right? Because structured day is supposed to be working on specific training activities as well as ILSP. A group setting may be considered, but only with the approval of the RDC and in extraordinary circumstances. Again, the qualifications for the ILSPs have changed. I encourage you all to look at that information in Appendix C. Again, we put in additional supervision requirements. If a provider has 2 or more ILSP staff, they are required to have a supervisor assigned to them. I would also suggest that going forward that the providers are going to want to look at how ILST caseloads work in conjunction with service coordination caseloads, because I know historically there have been some service coordinators that may have crossed over into providing ILST services, and that would be clearly a conflict of interest. So we going forward, we'll need to look at who and how those services are being provided. Again, 220 hours annually at the point in time that the new plan is approved. TBIS. Behavioral assessments are now limited to 10 hours. Again, we're encouraging providers to do a paper review of all available resources on that individual to get indicators as to what the person's behaviors are, what would be appropriate target behaviors to work on, and then what the intervention plan is to deal with those behaviors. Any behavior plan and details contained within the behavior plan should be consistent with the UAS. We would also encourage that the behavior plan also take into consideration what medications the individual is taking and when. And again, the UAS could serve as a resource there in terms of that background information. The number of hours to do the assessment is now limited to 10 hours per plan period. Hours are not provided to write the plan, and the service is limited to 240 hours annually, not to exceed 8 hours per day. That's a lot of behavioral intervention. Okay? We don't anticipate that will be at those limits. However, we know that there are circumstances where there are folks with some extreme behaviors, and there are situations in which it may be required for a short period of time. So we wanted the limit to be available should we need it. I would also suggest that going forward, we will be coming up with a format, a standardized format that we will be using for the development of behavior plans. We'll be seeking some input from the TBIS providers as to what they think that content of the behavior plan should entail. We do have a draft format that we're working on that we will be making available for comment. Training hours also cannot exceed 10 hours per service plan period, right? And we would, again, indicate that all of these hours are included in the total number of annual service hours. So the training hours, the behavioral assessment hours are all included with the within the 240 hours. Again, service plan limits begin at the approval of the next service plan. Structured day program. There's nothing new here in terms of the fact that structured day program services cannot be provided in the participant's home. The RDC and the Department of Health determine the appropriateness of the physical space of TBI waiver participants. And the reason why that is again, with the new HCBS regulations, we should not be providing structured day on the campus of other large facilities, in other areas where congregate care is provided, or in areas that are not considered to be fully integrated into the community. So we will be closely monitoring the locations of our structured day programs. Please expect that the RDCs will be coming out to do site visits. And we, again, that physical space has to meet the needs of the participant, has to ensure the participant's safety. must meet the provisions of the fire prevention and building codes, and they must be meet ADA requirements, which means that they must be accessible. And additionally, I know a number of providers have sought to try to develop structured day programs without walls. Those programs are only accessible and will only be approved if, in fact, there is a starting point and an end point, so that there's a common meeting place in the morning and a common departure place in the afternoon. And that is done for a number of reasons, but most importantly, make sure that everybody you started the day with is still there at the end of the day after you've done a significant community integration activity. So there must be a site that meets the site requirements that's available to those participants, should they also choose to not participate in whatever community integration activity is available to the participants that day. So if an individual chooses not to go out to the library, there needs to be a location where they can go for the day, and there needs to be sufficient staff and supervision and activities for that individual at the site that they remain back at. Okay. There's always been a question about whether the HCSS staff can attend with an individual to a structured day program. So our position on that is that it should be the exception to the rule. There needs to be sufficient justification as to why that particular individual needs that HCSS staff there. It should have the role of the HCSS staff and their presence at the structured day program should be there for the purposes of meeting the scope of practice of the PCA Level 2 individual, not to serve as an additional structured day staff person. So if that person is there for purposes of assisting with toileting, okay, or having to adjust an individual's seating for the day, having to help them get their coats on so that they can go, leave at the end of the day. It's for the purpose of providing PCA level activities while at the structured day, not to be the structured day staff person. We in addition, require that the structured day staff program have a staff person that's been previously trained as a PCA and CNA. So therefore, the need for that extra PCA staff person or HCSS person really should be an exception to the rule. So that is a situation that if a service coordinator is looking to include that extra service in the service plan, there needs to be very sufficient justification included in the individual's plan, and the RDC must approve that request. This service is reimbursed on an hourly basis and is not to exceed 10 hours a day. Now, this is an increase. And again, we talk about tolerance level, okay, how many hours of structured day can you put up with? I'm a little bit different. I do a 10-hour workday usually, so I know what it's like. But on the other hand, we put that additional time in there because we had gotten some feedback from providers that it doesn't allow them, if they're going out on a field trip or a special activity, it didn't allow them enough time to get back to home at night to do the activity and then include the travel time back and forth. So just to be on the safe side, we increased it to the 10 hours a day. Again, we encourage structured day staff to participate in the team meetings because they are spending a lot of time with individuals. They also have the opportunity to observe our waiver participants in different settings. And they also have a very objective perspective about what people's skills levels are. So it's really important for those structured day staff to also participate in team meetings and to participate in the development of the service plan. Substance abuse. The substance abuse program has been in the waiver for a very long time. However, it is probably our most, along with respite, our most underutilized program. As such, it was a very difficult argument with CMS to convince them that it needed to remain as a waiver service. CMS questioned us as to whether, why individuals can't access this service as a state plan service or in mainstream counseling and rehabilitative programs, such as Alcoholics Anonymous. Right? So as a result, you'll see that we've taken the requirements for the staff and up in terms of requiring that people be Case Act certified, because again, it was hard to explain how you could have a substance abuse program and only be supervised by a Case Act. So they want the person sitting in the room that's actually doing the counseling to be certified. And additionally, that it is limited to 3 hours a day. So at this point in time, we have, I believe, less than 10 individuals statewide that are using the service. So in terms of a significant impact on our waiver population, I think it would be a minimal impact going forward. So part of the delay in getting our waiver application approved was the department having to demonstrate to the Centers for Medicare and Medicaid what our rate methodology was for establishing our current rates. Traditionally, in the prior applications, the justification that was included was mostly that our rates were based on comparable services provided by the OPWDD system. Over time, CMS has gotten more stringent in its review and approval of rates. And they've frankly gotten much more scientific in their approach as to how rates are applied. So we had a tremendous negotiation in terms of what was our rate methodology, how did we establish the rates that we did, and what did we have to support how we arrived at those rates. Now, in most cases, the primary document that we have for purposes of justifying our utilization of services and our cost of those services has been our 372 reporting. The problem with that is several years ago, CMS disapproved our 372 reports based on the fact that we had faulty rate methodology. So it was somewhat of a catch-22. So the other problem, so as such, we have not really updated our 372 reporting pending resolving our rate methodology and getting the application approved. So the other problem that you have is that our 372 report is really for the sole purposes of justifying to CMS that we can support and document the fact that the cost of providing waiver services is less than the cost of providing institutional services. It really is not for the analysis of how much do the services cost. It has more to do with justifying that here are all the services we use, this is how much they cost, this is how many people use them, and yes, it's less than what it costs to provide those services to someone in an institutional setting. That is really the purpose of a 372, not to justify rate methodology. So we had to go through, and CMS has been very stringent in its training of states as of recent months. There have been multiple webinars provided to the states on how to effectively do rate methodology and how to establish rates and what CMS will require of a state before it will approve its application going forward. So as such, the only way that we were going to get our rates approved and to get our, quite frankly, get our application approved was to come up with a mechanism to demonstrate to CMS that we're looking at our rates, we're looking at the cost of services that our providers have, and that we will review those costs in comparison to the rates on a regular basis. So as such, in Appendix I and J of our application, you will see that we now reference a process of certified cost report. And what that basically means is that providers are going to have to complete a series of forms that explains what costs they incurred in the provision of waiver services, and that information will be submitted to the department on an annual basis, and then that information will be reviewed by the department. So, there've been some, and this does not just apply to the TBI waiver. It applies to other 1915C waivers that did not have cost reporting in place. Some of them did, the OMH 1915C did, but some of the other waivers did not. So our rates unit is moving forward to finalizing the criteria, finalizing the forms, and then there will be a training offered to providers on to how to complete the reports. Now, the important thing to remember on that is that providers are not going to be required to secure an independent financial audit, which tends to be somewhat burdensome. It is not going to be as complicated a process as cost reporting is for some of the other programs that are currently in place. It is going to be a modified version, and going forward, that training is going to be offered by the rates unit, and we will be working to ensure that providers get sufficient training to make sure that that information gets reported accurately, and hopefully without too much of a burden to the provider. So as I mentioned earlier, this is about half of the to-do list, but this is what we consider right now to be our first and foremost priorities. As I mentioned earlier, we've received a number of frequently asked questions to the TBI mailbox. We encourage you all to continue submitting those questions, but again, I caution you and encourage you all to please review the application first, because if you review the information, you're going to find that when you read the application, it's really redundant. We say the same thing 2 or 3 times over. So if you don't get it the first time, you're going to pick it up later in the application because we said it all over again. So that's why we encourage you to look at the application first. But to feel free to continue to submit your questions to the TBI mailbox at tbi@health.ny.gov. Then the next challenge is to revise the TBI program manual. We've gone back and forth with this concept. We don't know if it makes sense to combine with the NHTD program manual or to mimic the NHTD program manual. So right now we are proceeding with the plan to revise the TBI program manual, keep it as a separate document specific to TBI waiver services, and that is going to be quite a involved process. The other thing I want to note is that there's been some feedback about which document has more weight to it, okay? Is it the application or is it the TBI program manual? I will tell you that our 1915C application is our provider agreement with the Centers for Medicare and Medicaid. Upon audit, that application is initially what will serve as whether we're meeting the requirements of a 1915C waiver and if we are in fact meeting the terms and requirements of our application. CMS additionally takes into consideration a state's program and operating manuals, a state's regulations, any administrative directives, and any general information service notices, as well as whatever provisions are in the eMedNI and billing manuals. So there's a series of documents that all lead to the review and approval of the program and determine if, in fact, we're actually meeting the terms of the conditions of the 1915C waiver. So you'll see that that's why the TBI application is larger and more detailed than it's ever been in the past, because at this point in time, it meets the requirements that CMS gave to us. There were meetings, weekly meetings, basically since 2014, January 2014, regarding the content of this application, right? There were actual times in which we were directed to take and put specific language in the application, and that direction was by CMS. So CMS does not approve our program manual, they approve our application. Our program manual is the device that takes us and helps us operationalize the requirements of the application. So going forward, I encourage everyone to go to the application first, and then to seek the program manual out, which will give you the how-to of what we've identified in the application. However, that's going to take us some time to get to the point that that program manual is up and ready and able to help us out in those ways. So right now we're in a transitional time in which we're trying to meet the requirements as they're set forth in the application. Additionally, we still have to meet the requirements as they're set forth in the CMS technical guidelines that deal with the service definitions and deal with how 1915C applications work. And then we have to look to the program manual to figure out how certain things are going to translate into the new requirements that we have in the application during this transitional period. So those are the challenges that are ahead of us for the next month or two. We also recognize that many of our forms are outdated. As many of them as we could that we can make electronic, we want to move in that direction. So we will also be looking to revise our forms. We're going to be doing ongoing webinars to ensure compliance and give you with more information as to how we're going to implement things like the conflict of interest criteria, the alternate route for eligibility, the SRI reporting, and the cost reporting. I know there are a lot of people who've expressed concern that we're not getting information out to waiver participants. We've done one letter out to waiver participants advising them of the new application. There's a second letter that is, if it's not gone out in some regions, is in the process of going out to regions, which advises participants of the new service limits. Again, we are going to be looking to amend our forms at intake so that when a new applicant comes into the system, they are duly informed of the requirements and the service limits that we have in place now. So there is additionally, the regions will be conducting a series of regional forums, and I emphasize to all of you that these are regional forums directed at waiver participants, not at providers. So we are going to look to make them user-friendly. We are going to make them so that they are understandable by our service population, and the communication and the conversation will be directed to the individuals we serve. Providers with issues need to present those issues at their provider meetings. For those of you who are participating in today's webinar, you're getting credit per se for participation as a provider meeting. You need to print out your registration and keep it available in your files. I believe some of the regions have requested copies of them so that they, as they track whether you've participated in your 8 required provider meetings, that they have that information available. So I want to thank Belinda down in the Binghamton region who came up with that idea. It was a great idea, and it will hopefully work out to benefit the providers. Additionally, we will be doing the procedural updates for the administrative law judges so that they are familiar with the alternate route process and how we're going to choose to notify participants of fair hearing decisions and the timing involved in the notifications of those decisions. So those are our most immediate issues. Again, you have our mailbox. The frequently asked questions will be coming out. As usual, I try to keep myself accessible and available to all of you for questions. There's one more issue that I'd like to close with, and that seems to be an attitude that somehow we are in a state of chaos. And I will tell you that the regional resource development centers are doing their best to accommodate the number and the quick changes that are occurring as this process evolves. They are doing their best with the amount of communication that we have with them via email, conference call, and their ability to then disseminate this information out to providers and participants. As always, our first requirement is to that of our service recipients, and they remain our primary focus. And we will continue to make them our first and primary contact for information and getting information out to them. So if there is a delay in the communication process, I apologize. But first and foremost, our priority is to reach out to our waiver participants. In the meantime, we also have to continue that we work to bring people onto the waiver. So we have a commitment to do our outreach and continue our intake process and to keep them moving through the system so that they're not waiting for services as well. So it's a tremendous juggling process with a very limited staff and limited resources. And at this point in time, in clear confidence, I say that I believe that our 9 regional contractors are doing their best with the resources they have available to them. Secondly, I'd like to address the issue of individuals receiving notices of decision and the fact that because of the changes in this application, the people are now being denied services. I've done a statewide survey. I've spoken to all of the regional resource development centers. The best that we can come up with is that there are approximately 9 individuals who have received an NOD, all right? And that means that they've had a first UAS done, a second UAS done, and they've received an NOD. In those cases, we're working with those individuals to bring them in for a case conference so that we can further describe the alternate route. We've contacted them. We've asked them to seek fair hearings and explained the aid to continue process so that they can continue to get services while these discussions evolve. In the meantime, we are doing our best to secure and find ways to get that other clinical assessment completed for them. And we are doing our best to make sure that we have a good case record for those professionals to look at the point in time that we secure the clinical assessment. So at this point in time, there will be no NOD issued to any waiver participant for an issue related to level of care without prior review and approval by the Department of Health. So I'm quite comfortable in the fact that we are very closely monitoring what individuals this has impacted and how many folks are out there that are being, have level of care issues. So with that said, I'd like to thank you all for your participation today. We are going to be posting the PowerPoint presentation online. It will most likely be in 2 locations, again, as I mentioned earlier, on the MRT 90 website and then at the TBI website for the Department of Health. I encourage you all to be patient. And again, as we look to make modifications to the program manual and forms, your input is going to be critical to how we move forward and what changes we make.
Thanks, Beth. Nice job. And folks, stay tuned both to the website where these slides will be posted and email announcements of the future webinars and the regional meetings that have been mentioned several times today. We'll also be capturing the questions. There was a lot of repetition in the questions that were posted online today. Actually, I think every one of the questions posted online has also been emailed to us. So when you get the frequently asked questions document that Beth is talking about, you should have answers to all of your questions. Thank you, Beth.
Thank you. Have a good day.